Anyway, welcome everybody. Please note this, that all of the information and opinions that are expressed on any of our Zooms that we're doing or in written form are intended to address specific questions some of you have asked with providing information described on the program and are not designed to constitute complete or professional advice or my recommendations or anyone else's recommendations. Remember that we are not acting or relying upon information contained in any of the Zooms or written material shared. Please do not do that without seeking the advice of a medical professional. And I really want to say that because you may get information that's shared, emails or Zooms that you don't agree with. And there's no way that we can totally prevent that. You just have to formulate your own opinions from all the information that is shared with you. Okay? Are we good?
Sure.
Okay. All right. And I want to just welcome Gail. How are you, Gail? Nice to see you.
Very good. Thank you, Shelley.
And I'm so happy Suzanne is here. Welcome, Suzanne. Good to see your face. Nice to see you. And Chris, welcome, Chris. Nice to see you.
Thank you.
To the group. And Carol. Hello, Carol. Nice to have you here. Welcome. I know Carol in my other life.
Yeah.
It's really fun to have you on, Carol. Welcome. And then I think I saw Dr. Kiel here already, and I'm thrilled. So we are going to go ahead and because that's true. And welcome, Annie, by the way.
Thank you.
Even though I don't see your face, I want to welcome you. Okay. I'm going to turn the program over to Diane.
Okay, great. Thanks, Shelley. I'm Diane, and I have the pleasure of introducing Dr. Douglas Kiel. Dr. Kiel is a senior scientist in the Marcus Institute for Aging Research Musculoskeletal Research Center at Harvard, Hebrew Senior Life. He's also a professor of medicine at Harvard Medical School, an associate member of the Broad Institute of MIT, and Harvard and past president of the ASBMR. Not sure what that is, but I'm sure he'll tell us. Dr. Kiel conducts research on musculoskeletal diseases affecting older adults who are part of the Framingham osteoporosis study, including lifestyle and genetic determinants of osteoporosis and fractures, as well as sarcopenia. His current work focuses on the genetics of bone microarchitecture phenotypes, the role of the gut microbiome on skeletal structure, and fracture prediction using HR-PQCT. He has also performed multiple randomized controlled trials to test the efficacy of treatments for osteoporosis and falls. Dr. Kiel is one of a core group who created the IFMRS Musculoskeletal Knowledge Portal. Over to you, Doctor.
Good evening, everybody. I'm so glad that you're at our Zoom conference tonight. I was asked by the National Osteoporosis Foundation to be here with you to answer, I guess, any questions you have about osteoporosis. I did get some questions in advance that I tried to answer. And from looking at the questions, seems like everyone is focused on what goes in your mouth and how it might help your skeleton. But I'm open to any way you would like to conduct the session tonight. I'm more of a generalist. I have some areas that I have researched, but if I don't know an answer to your questions, I can certainly get back to you or look it up. But how do you want to handle this, Shelley?
Well, thank you, Dr. Kiel. First of all, thank you so much for your time tonight. And we are, of the answers that you have, I'm sure some of you have questions as well. But one question that I would love you to touch on is, and I think other people would like to ask you questions as well, but you mentioned in your responses to our questions that it's important to have 7 grams of protein for every 20 pounds of weight in a day. And you also said that the source of the protein was important and that the acids released into the bloodstream are neutralized with calcium and other buffers. So my question is that the reason why that much protein is recommended, due to calcium getting depleted through the breakdown?
Yeah, let me clarify. This was when you eat protein, protein can come from different sources. Generally, it's categorized into animal protein and non-animal protein, namely plant protein. And when animal protein is eaten and it's broken down and digested, it's composed of certain building blocks called amino acids. And in the digestion process, there is some acid that is released into the blood. Now, your blood maintains the acid content very tightly. It doesn't deviate too much because it can buffer. It has several buffering systems. One of the buffering systems is your bone. And there was some basic research showing that if you had a lot of acid floating around and the bone buffers it, it would have to exchange calcium in order to absorb the acid, the hydrogen ions that are making up the acid. And so there was a fear that if you ate a lot of animal protein, your acid would go up and then your bone would leach out calcium in buffering the acid. So everyone was having concerns about this, and they would say, don't eat that much protein, it's bad for the acid. But it turns out, while you might observe that in experiments, when you actually look at populations like us that eat different proteins, there was no evidence that eating animal protein made your bones fare worse than eating other proteins. So I think that theoretically there is this observation of the acid, but when you look at research about people in large numbers, the higher protein intake was actually good for your bone. There's very few people that eat too much protein. And as we get older, the old tea and toast type of diet that people joke about, but is true. As we get older, sometimes the diet changes so that there's inadequate protein. And I would say that's more of a concern in older adults than getting too much protein.
That's really interesting. And then on that same subject, I don't want to, you said the source was important, the source of protein. So what were you meaning by that?
What I meant important is the more acid is produced with the animal protein than with the plant protein. But in essence, we found in our research that men and women who ate more protein, regardless of whether it was animal or plant, still had better bones than those who had low protein. So even though you could show this acid phenomenon, the bottom line is having adequate protein from either plant or animal is important to maintain your musculoskeletal system. Musculoskeletal is a mouthful, but it's everything that keeps us upright and walking and moving. It's our muscles, our bones, our joints. Collectively, we call that the musculoskeletal system.
Really good. And I don't want to monopolize questions, but Diane, you look like you have one.
I just wanted to ask a related question. When I read the answers to your to our questions, doctor, you mentioned adequate protein, and I'd like you to just share what you mean in lay language. 7 grams, 20 pounds, like how much protein, 3 times a day. I wonder if you could just give us some general guidance about, if you're over 55 or 60 and you have osteoporosis, what should you really be aiming for in a more day-to-day language, if you could, please.
Sure. Well, the National Academy of Medicine puts out the recommendation of for every kilogram of body weight. So if you're the people say the average weight that people use is 70 kilogram person. So if you're 70 kilograms, it's roughly 150 pounds, something like that. And if you weigh that much, then if you take 70 kilograms and you multiply it by 0.8 grams, you have 56 grams of protein. So you need, if you're a lighter, if you weigh less, say you weigh 100 pounds, or let's say you weigh 50 kilograms, which is a little over 110 pounds, then you multiply 50 kilograms times 0.8, and you only need 40 grams. So if you look at the labels on foods, you can find out how many grams of protein are in eggs and in meat or in plants. And so most people, you don't have to worry about it unless you have if one of you on the phone is a vegan and you are not careful about the types of foods that you're eating because it's too difficult to prepare them or whatever you're doing, then you may under eat protein. But there's hardly anyone in America in your age ranges that I see on your pictures. If I had to guess your age, you're probably in that average 56 kilograms or 40 kilograms of, 40 grams of protein. So you don't have to worry about it too much. If you have osteoporosis, a lot of these questions were, what about the vitamins? What about the fatty acids? And what about the protein? We don't eat vitamins, we don't eat fatty acids, and we don't eat protein. That's what we try to measure when we do research to sort of figure out what is good and what's bad. We eat food, and each food that you choose to eat has vitamins, which are sometimes referred to as micronutrients, and they have fats, carbohydrates, and proteins, which are the macronutrients. And so you can't pick, unless you just take, if you're a vitamin person and you just want to wolf down a lot of vitamins. I think the bottom line is to have and this sounds trivial to say and trite, but a well-rounded diet that's not, so heavy in carbohydrates, but lacking in green leafy vegetables and fruits. We have studied dietary quality. So if you eat a lot of fruits and vegetables, we found that your bone density will be better than if you are not eating as many fruits and vegetables. So just like everyone says, eat fruits and vegetables because it's good for your heart, it's good for your general health, it is also good for the skeletal health, for your bones. And so that's what I would recommend as a balanced diet. There's no special bone diet per se.
Thank you.
Trina?
There's Trina. Still on mute. Oh,
go.
there you go.
Yeah. You are studying microarchitecture, which I believe is looking at the bone might be, the scan might show that the bone is very diffuse, but does that address the actual strength of the bone? Is that what you've done research on?
Yes. How many of you on the phone have had a bone density test? I see a number of you. So have you ever seen the little picture that comes out on the report? It looks like a little skeleton picture.
Yeah.
And then there's a number that you look at, the bone density, and it's a T-score, which tells you how good it is. And it takes about, a minute or two to get the scan, and you do the hip, etc. Well, it gives the amount of mineral in whatever bone that's being scanned, like the hip or the spine. It just gives the mineral. It's a two-dimensional test, and you just lie there and the X-ray beam goes through you, and it can figure out how much bone mineral is getting in the way of the beam because less comes out on the other end. And so you can measure the density. But if you look at a skeleton really close up, or if you look at anything, if you did a bone density test on an airplane wing and you got a value and said, hey, it's a lot of metal here, it's pretty good, you wouldn't necessarily be confident that the airplane wing, just because it has a lot of metal, is going to be not breaking during the flight. That's because the metal is built in a way to give it the maximum strength. And when we do a bone density test that your doctor orders, we don't get the structure of the bone, we just get a single number, the density. The equipment that we're using in our research that's not used clinically in this country gives you the architecture. It looks like Fantastic Voyage through the bone. You can actually see all those little pieces connected to each other in a honeycomb pattern. You can see little holes that are all over the bone, and you can actually do a pretty good job of calculating the strength, the way they do to calculate the strength of an airplane wing or the strength of a high-rise building. When you go in, if you're going into a high-rise building, you're pretty confident that the building's not going to fall down on you. And that's because the engineers, they build it in a way to maximize the strength of the supporting structures. And the body does that with the skeleton. When you exercise, the body responds by making the bone structure stronger. And so when we measure things with our special equipment, we get more information than what you get with the clinical test that you've all had, the bone density test. We hope that it will someday be useful in clinical practice. Right now it's not, but we showed in one of our projects that if you had a bone density test that you get from the doctor, and then you have this high resolution architecture test, there's additional information about the risk for a fracture that goes above and beyond the test that is being used clinically. So it adds additional information to knowing what your risk is for fracture.
Thank you.
Marissa.
How do you get that architectural scan? Right?
Right now, it's only done for research purposes.
Okay, only done for research. Okay, yes, thank you.
Yes, there's one company in the world that makes these things that you have to import them from Switzerland. And it's a little company, and there's quite a few machines in the US which are doing the research to understand, like, let me give you an example. Does anyone have diabetes? There's a diabetes called type 2 diabetes you get as a grown-up, not as a child. And it turns out that if you have diabetes, your bone density is high. And you would say, oh, I'm in good shape from the bone standpoint because I got good bone density. But if you do the architecture test on a research basis, you will see that there are little holes in parts of the bone on the outside part, the envelope. Like if you did your arm, the arm looks like a tube with honeycomb in the middle and a very thick outer part. Well, the outer part's full of these holes like Swiss cheese. The overall bone density looks okay, and you might go away thinking, hey, I'm fine. But the little holes may not be good for the bone strength. So if you fall down, you might be thinking you're okay because you're strong bones. But if you have a lot of those little holes shown on the scan that we do, it might mean your bone strength is not so good. And that's why there's this observation that even though people with diabetes have higher bone density, they still have a greater chance of having a fracture. It's like a conundrum. Why would that be? It's probably some other properties that happen to the bone with diabetes, but it points out that there's more to learn about the architecture of the skeleton from these fancy imaging tests that we have now.
I wish they were available.
I think someday they will.
I have a question, if you would, Dr. Kiel. In terms of what you just went over, how do the NTX and the CTX scores, are those good predictors in terms of what we do have available to us now?
Yes, how many people on the phone have had those tests? There's a lot of jargon in this medical profession. NTX or CTX or P1NP. There are blood tests that can be done to measure how rapidly the bone is going through its normal cycle of breaking down and then building up. And these tests that can be done in the blood can tell you whether you're accelerating the turning over process, which can make you a little vulnerable to fracture, and can tell you whether the medications you're taking are working well or not. I think of it as, you've all seen when they start paving I-95 or the Mass Pike, you watch those trucks with the big things and they're scraping, and then you see the sign, rough road ahead, but you can still drive on it, but there's all these little like gravelly divots and the pavement's like shaved off and put in a dump truck that takes it away. And you drive on the pike for a few weeks, and then one day you come back and overnight someone put down some fresh pavement and it's nice and smooth again. Well, your skeleton is not some blob that just sits there not changing. It's always changing. It's getting rid of old bone and replacing new bone. And so in 1 year, all the bone in your body's it's got some new bone in it. The old bone's gone. This occurs in very small things like the pavement on the highways. And those blood tests can tell whether the truck's really going crazy and like skimming off a whole bunch of pavement. And the more of that's in your blood, the more rapid and more intense this normal cycle is occurring. One of the theories of osteoporosis is that as we get older, especially after menopause, the trucks that break the pavement down, the osteoclast bone cells, can actually outperform the pavers, the osteoblasts that lay down the new bone. So every time a little divot is carved out and then smoothed over, there's a little bit less pavement than there was before it happened. And if that happens over and over through a lifetime, there's a little bit of a net deficit on each of these cycles. And that's why with aging, we lose bone, because it's a normal turning over, but it's just out of balance. And those blood tests that Shelley mentioned are an indication of whether it's revved up or not.
Is one of them more important than the other? When, you know, if you were to, one of us were to request wanting to have those tests, usually doctors won't do both. So which one would you say is a better predictor to
I
ask?
think they're all potentially useful, but most doctors are not ordering them. You probably have to go to a specialist. Your general primary care doc is not ordering this test. And it's not as much which one's better, but it's better to get it done in the same one done if you're getting it more than once. It's like, let's say you are starting a medication and you want to know whether it's working. That medication might change the values of the blood test. So you want to get the blood test by the same lab, and you want to collect it the same time of the day, which is usually in the morning before you eat, because sometimes those tests they vary diurnally. So even if you're just like lying still, not even eating or anything, it might go up in the morning and then down in the afternoon. So if you measure it at two different times, no matter how good the test is, it's not going to be very useful. So it's more important to get it at the same time and go to the same lab or the same practice that sends it hopefully to the same lab. But again, they're not used that often. And I don't know how many people, and it sounds like Shelley's had them, but have you all had these blood tests? Suzanne has had it. Which one did you have, Suzanne?
I had the NTX.
NTX.
Yep.
These basically, I can tell you, they have these abbreviations, but what they are they're measurements of pieces of collagen. Collagen, in addition to being injected for cosmetic surgery, is the underlying protein in your bone. And the collagen is hooked together so that it's all evenly distributed and calcified. And as you break down the old bone, pieces of this collagen float into your blood and you measure it. So if your bone is breaking down a lot of it's floating into the blood, and it's a sign of higher bone turnover. If you're turning over quicker, you can guess that each one of those little cycles is a deficit. So if you're going really slow, you don't get as many cycles of deficits. So that's what some of the medications do. They put the brakes on the rapidity of these normal turning over cycles.
Oh, thank you. That's great. I love that, the paving explanation. That's fantastic.
Yeah.
Yeah, I saw a picture. The reason I thought of this, someone sent me one of those really close-up electron microscope pictures. If you've ever seen those, it was a picture of a single osteoclast cell. It was like larger than life, of course, in this picture. And you would not have any difficulty in seeing it had gone along the surface of the bone like a little creature, and it left a little eaten up area that looked exactly like those machines on the highway. I was like stunned. I said, I've seen this before. It was the same pattern. It looked like the asphalt, that roughened asphalt.
Wow.
So it brought this picture to mind, and it really it's just the same process, but in a biologic sense.
That's so interesting, kind of like corrugated.
Yes, it's like this. I should pull up a picture. It's a picture's worth 1,000 words. Maybe as we're talking, I could find it.
I don't want to monopolize the question, so who else?
I have a question.
Oh, great.
Sure.
You said there were various types of proteins. That we have fish, we have red meat, and we have vegetable. Which type would you recommend?
Well, I think that all of the protein that we've studied seem to be favorable for, the bone health.
Mhm.
And so I think it's good to eat a mixture of protein sources. The animal proteins have essential amino acids that may be more difficult to get from other sources. And the fish have the famous, polyunsaturated fatty acids, the oily fish, and that's good for your circulation. And so I think a little bit of protein from all sources is the balanced approach that I recommend. Unless you're strong feelings about being a vegan, then you have to really be careful, because if you eat all carbs and you don't get the right mixture of, say, beans and other vegetables, because you're not getting the eggs, if you're a vegan, you have to be a little bit more careful. You're not taking any dairy, so you have to get your calcium from vegetables like kale or broccoli, which don't have as much calcium. So I'd say a balance of protein is really probably the safest bet.
Okay. I have another question about calcium supplements. What type of supplement would you recommend? I know we have citrate and we have calcium carbonate.
Yeah, people have obsessed about calcium supplements. I primarily tell my patients it's better to not eat supplements, but eat food. And so I tell people that if they can get their calcium from diet, that's the best. Supplements, calcium carbonate, you mentioned, is one, calcium gluconate's another. And some people say that on an empty stomach, the carbonate is not absorbed as well. But the way to get around that, since they're cheaper generally, is just take it with a meal. Just take the take the calcium with a meal, and then you can take calcium carbonate. So I think calcium supplements should be reserved if you have a certain diet that you're not getting calcium from foods, or if you have intolerance of dairy products because you have lactose intolerance, you can get Lactaid and still get the calcium. So I do recommend people trying to get their calcium from the diet. All the supplements are reasonable. There used to be a test, you put half vinegar and half water, put your calcium tablet in there, and if it's still there, 15 minutes later, then it's probably not dissolving very well in your stomach.
Okay, thank you.
But again, foods are the way to go, not vitamins or mineral supplements. I still heavily recommend foods.
Trina, did you want to say something? You're on. Oh, there
Quick
you are.
follow-up question. Are fortified foods, which category do they fall in? Supplement or food? Like orange juice?
Yes. they are foods in which the producers have supplemented extra amounts. So I guess that's maybe that's halfway between the two. They put some calcium in orange juice. So if you can't get it from the dairy products because you're intolerant, that's okay too. There was a period where there was a big publicity that calcium supplements actually might cause you to have more heart attacks, like it's going to clog up your arteries. That's not true.
Okay.
But you don't have to like do mega calcium. Just if you look at the RDA, that's the recommended daily allowance. It's 1200 milligrams of calcium.
Yeah.
A glass of milk has 300. Yogurt has 150. So, if you can't get that from your diet, then a calcium supplement once a day is a reasonable thing to do. Let me show you this picture. I found it. I'm going to share my desktop.
Oh, wow.
There. Does that not look like I-95 there? That is the osteoclast.
Yeah.
It's
Yeah.
it's a healthy thing. That's the osteoblast. That's
Wow.
the cell. That's the paver. And look, is this the most beautiful thing you've ever seen? It looks like a spider or something underwater,
Yeah.
like a crab. These are the most abundant cells in your skeleton. They're called the osteocytes. They're just sitting there in the skeleton. People they're sitting in little caves, like little holes. And people thought, oh, they're just like retired osteoblasts. They did their paving and now they're just like sitting back and doing absolutely nothing. But it's like a giant network of these little connections, and they're all connected. It's like a universal, everyone's connected to everyone in this giant network. These people think that these cells are communicating and telling, like if you exercise, these cells, like they're jiggling around, and these little canaliculi, they're called, they communicate and they start to instruct the skeleton to build more bone. They sense that you're exercising, and they start getting to, they whistle and they say, come on, let's make some bone. And so they are very, this is what happens let me see if this will work.
Oh, wow.
No, it's not. I just had a little movie here. But anyway, these cells are just beautiful things, and they are very sensitive to anything you do. That's why exercise of any kind, walking, anything you can do will stimulate these cells, because they think there's fluid in here and it sloshes back and forth. And if it's sloshing a lot, it tells the cell to start working. And if you're just lying in bed because you have the flu and you're not getting up at all, there's no fluid sloshing around and the cells just are dormant, not telling your skeleton to build new bone.
Oh, interesting.
Very interesting.
Wow. Have they ever tried to replicate those cells?
Replicate them, meaning like
Meaning to
inject
grow them?
People do try to grow them for research so they can study them.
Mm-hmm.
There's one researcher in our research community who has these beautiful videos. This is like a still shot. If your kids sent you a video on your cell phone, this woman can image the cells, and they're moving. All those little things are like jiggling around, and
Oh,
you can see things going through them. Little balls are bouncing around in there.
wow.
They're shooting off these little pellets to communicate. It's fantastic.
Wow, that's
Most of
awesome.
us think this, you don't see your bones, so you don't know that they're like it's like a reef, in the ocean. There's all these living corals, and there's a
Yep.
lot of action going on in the skeleton. Your skeleton gets the blood supply that every other organ gets. All the things you eat are, just going right in there. So it is important to have enough protein for those cells, enough energy, the carbohydrate energy that you need, the fats to make new cells. That's why a balanced diet is good for the whole body, because all the cells need all these basic building blocks. Yes, Marissa.
And caffeine, it's like my big vice, and my primary has not told me to stop, but I'm seeing a specialist in May, and I'm kind of wondering what they're going to say, right?
How many cups a day?
Just one in the morning.
Oh, okay. When you drink coffee, don't you have to urinate more?
Possibly.
It has a diuretic.
Okay.
Caffeine has a diuretic effect. If you drink a couple of cups, you might find yourself going to the toilet more frequently, and you lose calcium in the urine from a diuretic like that. So theoretically, the more caffeine you have, the more calcium will be lost in the urine. We studied that in the Framingham study 25 years ago and found that heavy caffeine users had lower bone density.
Wow.
Now, what's heavy? Your 1 cup
Right.
a day is not heavy. There's caffeine in Coca-Cola too, and Mountain Dew, and there's more caffeine in coffee, depending how you brew it. If you drip the coffee versus instant, there's more caffeine. There's about 90 to 100 grams of caffeine in a brewed cup of coffee. I think Mountain Dew is like 60 or 70 grams of caffeine. That's the bit on caffeine, but 1 cup a day, no problem.
Is there any correlation between that you've read about at all between interstitial cystitis and osteoporosis?
I've never seen the two things connected. Have you heard something about that?
No, I haven't, but I
Oh, okay.
heard that from,
Yes, I see Diane has a hand up. Oh, and then Jane has a virtual hand up.
I'll be quick. I just on the coffee or the caffeine issue. What about if you switch to decaf? Is that less of a concern?
Yes.
That's one question. And then the other question is, why do you think doctors aren't prescribing the NTX? My endocrinologist has said she doesn't think it will tell me anything right now because I'm on forteo. So I'm puzzled about that because I want a better assessment than just the bone density. So I'd be grateful if you could answer those questions.
Okay. So what is the value of those tests of the collagen breakdown? When you start a medication, some practitioners, they don't want either the patient, like yourselves, or the doctor wants to see that the medication's doing what it should do. So if you're taking Fosamax, for example, Fosamax is supposed to slow down the turnover and reduce the NTX because there's less breakdown. If you had to wait a year to get your follow-up bone density test, and then you say, oh my gosh, if only I had known it wasn't working, I could have done something sooner. Now a whole year went by. Now you're telling me my bone density went down. If we had gotten an NTX test, and it told me that, wow, it's not going down the way we expected, then maybe another medication could be, used. However, in the studies of drugs like Fosamax, women in those studies who took the Fosamax and their NTX didn't go down and their bone density didn't go up had fewer fractures than the women who took the placebo, even though their bone density didn't go up and they didn't slow down their bone turnover because they were on a placebo. So there's not a one-to-one correlation between what you measure in the blood on those NTX or CTX tests and what it means in terms of your fracture risk. It doesn't always go one-to-one. And if you give up on it, let's say you started Fosamax, come in 3 months later or 1 month later for one of those NTX tests, and then you said, oh, it's not low enough, we're stopping the Fosamax, you might be making the wrong decision. Because if you took it for a year, even though your bone density didn't go up that much, you're probably still protected. And it's probably because, the mineral is still it's still thicker, in different places, but the number didn't go up very much, but the bone is still better and you don't have as many fractures. So even the best tests that we have don't always tell us precisely that the drug isn't working or it is working. Diane, I saw you nodding, which made me think that you went through this situation and that's how you ended up on forteo.
Yeah, I was on Fosamax for 2 years and it worked great the first year. And then the second year, my bone density got worse. I was shocked. And so the doctor paused and then she recommended forteo, which is a daily shot. I know some of the other folks on this call are also on that. And I'm really concerned because I'm trying to gauge my real risk. Like, is this really bad? Should I curtail things? I don't want to do that. I do everything possible, diet, exercise, everything, calcium, but I want to get a truer picture of what's going on besides just a DEXA scan.
So you had, your bone density was low enough to initiate the treatment, obviously.
3.7.
Minus 3.7?
On the spine.
Yes. Well, those of you who are knowing about the T-scores, that's kind of a bad score to have in terms of, it's like more than 3.5 standard deviations below a 30-year-old healthy woman. And that might have been low enough at the beginning to have some physicians prescribe the forteo right from the beginning and not even starting with the Fosamax. There's been a gradual change in our approach to the treatment of osteoporosis as we get new medications. Some of the injectable medications like forteo or Evenity, well, not so much with Prolia, but Evenity and forteo and abaloparatide, which is Tymlos.
Mm-hmm.
These are injectable drugs that cost anywhere from $3,000 to $4,000 a month. They're covered with some pre-approvals, but they actually, instead of just slowing down that cycle, they get that osteoblast cell and jazz it up so that it makes new bone. It's not just slowing down the breakdown part of the cycle, but they're more expensive. They're injectable, and you only take them for a couple years, just to be on the safe side. But usually the decision to use those more expensive injectable drugs is based on how low your T-score is, whether you've had a lot of fractures. And so at minus 3.7, some docs might have started with the teriparatide or the called PTH, forteo. Yeah. But, you know, I will tell you that, did you go to the same DEXA machine for all 3 readings?
2.
But you had one at the beginning before you started.
Yeah, it was 3.3. Oh, sorry, it's 3.6. And then it got better on the forteo for the first year. It was down to 3.2, which was terrific. And then in the second year of the Fosamax stopped working and it dipped down to negative 3.7.
And where do you live?
Dedham,
Dedham. And where did you have your test? Just out
the
of
Brigham,
curiosity.
the Brigham.
You see Merrill LaBeouf?
No, Sharon Chow.
Sharon Chow. Well, then you know you're going to a very good bone density machine. You know the person analyzing the results is good. But, you know, there is, you know, whether that's really significant, significantly different, you know, and making an abrupt change in therapy based on, you know, you started at minus 3.6, then you went less negative, minus 3.2, then you were minus 3.7. In actuality, you're in that category where you had 2 years of Fosamax and your bone density sort of was about the same. It
got worse.
Well, 3.6 and 3.7 is like if you take your blood pressure and you told me, oh my gosh, my blood pressure, it was 140 over 70. And yesterday, when I was taking my pills, it was 138 over 70.
It had improved the first year, and then it turned around and it got much worse.
Yes, there's something called regression to the mean.
Mm-hmm.
And anytime you repeat a test, you get a test, and it's part of, if you keep doing the test, if I did a bone density test on you without the radiation exposure 100 times in the same day, you would get a Bell distribution. But I don't do it 100 times, I do it once. So there's a chance the one time I do it, it's at the low side of the bell-shaped curve. Then you come back a year later and I do it again. The chances are it's going to be closer to the middle of the bell-shaped curve, because every time you do something, there's more measurements, you know, that piling up at the middle of the bell-shaped curve. It's called regression to the mean because every single measurement is an estimate of that distribution. And so the bottom line the point I'm trying to get across is you can't be so nervous about these small changes in a test, which has you know, it's not that precise. If you keep repeating it, it's pretty good, but you shouldn't like start obsessing about small changes. And in fact, in the studies, if you take Fosamax and you don't change your bone density, you're still better off than not taking Fosamax. There's a protection about taking Fosamax. So it's a very difficult clinical decision to give up on a drug just based on the bone density follow-up test. Sometimes you stick with it. And if you're severe, like your value was, Diane, it was more on the low end. It was in the more moderately severe, low, it was low. You might want to use those more expensive drugs like you're taking now, forteo.
Thank you.
Sure. And I think that Jane had her virtual hand up.
Yeah, I have more of a specific question. I realize that steroids contribute to bone loss. I'm on prednisone. And my endocrinologist feels that that was a major contributor. What I'm wondering is, I also have bursitis. Will cortisone shots also contribute to it?
You get more steroid when you take those pills. Like if you were on steroids for something else by mouth.
Say again?
If you take the prednisone by mouth, there's much more effect on the bone than a cortisone shot once in a while.
Okay, yeah, I take a very small dose of prednisone now. It's only a half a milligram, I think, or something. No, 2.5 milligrams.
Yeah, 2.5 milligrams, getting down low enough that it's not as much of a concern. Even when you have asthma and you take those puffers, some of the puffers have little bits of cortisone like drugs in there, and they get absorbed in your body and they can have a small effect, but it's a much lower exposure than a prednisone tablet.
Okay, yeah, this is I'm an immunotherapy, Pat.
Yep.
But so would a cortisone shot for bursitis also contribute to my hips getting worse?
Unless you had it like every week or something.
Okay.
I mean, it's just occasional, right?
Okay, so
it doesn't spread out.
Every...
It's not as much in there in that one shot, and you don't take it every day, so it's not as bad as the pill.
Okay, thank you.
Yep, sure. And I see Annie S.
Yes, I have a question. Fosamax has a pretty significant risk of osteonecrosis. Do the injectables have that higher risk also, or is it lower risk for osteonecrosis?
Does everyone know what osteonecrosis is?
The bone dies. So like if you were to get a tooth extracted or whatever, the socket doesn't heal very well at all. And the bone can just die and grow, and it leads to major complications and sometimes major oral surgery.
So Annie said, I'm so glad you asked this. Annie said that it's a significant risk.
Well, I've seen in my office, we've had patients on Fosamax, and we've seen, based on those that are on Fosamax, that percentage, we feel it's a high risk of osteonecrosis. Even where you had a tooth that might be periodontal, I'm a dentist. So if you had a tooth that was periodontally involved, and basically you could almost sneeze the tooth out, we take out the tooth, and we've gotten osteonecrosis, no matter how gentle you were, anything, we've seen it.
Yes, osteonecrosis was first observed when the Fosamax-like drugs were being given to cancer patients who had cancer that spread to the bones, metastatic cancer, and the Fosamax-like drugs were being given in very high doses to prevent the bony pain and spread and the worsening of the metastatic cancer. And it was also seen with in people who had poor oral hygiene or had extractions while they were getting these high doses to treat the cancer. But then cases started to turn up in people who didn't have cancer, who were just getting regular osteoporosis kind of Fosamax treatments. And it created quite a stir. And it got into the press, and the dentists were all up in arms about it because they started to notice it, like Annie's talking about. And over time, once we got an idea of how common it occurred with regular osteoporosis treatments, it was extremely uncommon. And the Academy of Oral Surgery and all the dentists have put out guidelines to help other dentists and oral surgeons decide about how to handle extractions and make sure, like when I start someone on Fosamax, I check their oral cavity, I check for poor oral hygiene, and if I see that there's going to be a lot of big dental work, periodontal disease, or extractions, I will wait to start the bisphosphonate drugs. But in an average person who doesn't have a terrible oral hygiene situation, it's not a common side effect. All drugs have side effects, and it's one of several side effects that is a very uncommon side effect, but it has gotten so much press attention that patients and doctors and dentists and everyone is so afraid of a rare side effect that they are actually going against the recommendations to get treated. So thousands, hundreds of thousands of women who are breaking their hips are leaving the hospital after a hip fracture with no treatment.
Well,
But-
what about the injectables?
The injectables, there are several types of
Taking risks?
injectables. The one that was being taken by Diane, forteo, that is an anabolic drug that has no osteonecrosis risk.
Okay.
Another one that's called abaloparatide, or Tymlos is the brand name. There's no osteonecrosis risk. And the third one is Evenity, which is romosozumab, the newest one. There's no risk, but the ones that are Fosamax, Actonel, the Sally Fields one, ibandronate, and zoledronic acid, which is reclassed, the injectable. So that's one you get IV once a year.
Right.
That one,
Get patients on that.
that's in the group called anti-resorptive. It prevents that osteoclast from digging the trenches. Those are all capable of causing osteonecrosis, but
Because basically you're left with stale bone.
right. And if you decide that you're afraid of stale bone and you'll take your chances, if you break your hip, you might be dead and you won't have to worry about stale bones anymore.
But what if you do the injectable?
If you do the injectables that are in the Tymlos, Evenity, or the forteo, those are the more expensive ones that build the bone brand new. They don't have that problem. But Prolia, which is advertised heavily on the evening news, I noticed, those great commercials where the woman's about ready to trip over her, grandson or something. That one is associated with the osteonecrosis, like is the Fosamax drugs. But again, they are low risk. When you take how many people are taking cholesterol lowering pills?
Nope.
Did you know, Lillian, that you could have a fatal muscle problem where your muscles break down and you have kidney failure and die?
Thanks, Doc.
Oh,
Yeah, I take it every day. Who's taking look at the blood pressure pills. They all have these rare side effects. There's virtually nothing that we prescribe that there is some finite amount of risk. And we try to do the best we can to avoid the risk. Like in the osteonecrosis, we try to stress oral hygiene, delay extractions while but if you're about to start the medications, get your extractions first, and things like that to mitigate any of the low risk but terrible side effects of any medications. But it's gotten, the pendulum has swung so severely against treatment that you can go on the website, and NOF will stand behind this too. There are these websites that are like misinformation, fake news about magnifying the risks and minimizing the benefits of treating osteoporosis. You would never leave the hospital after a heart attack without a cholesterol pill, aspirin, and a drug called a beta blocker. If you did, it would be malpractice. If you have a hip fracture, almost all of you will leave the hospital and never get treated for osteoporosis. That's
Okay.
how bad it's going. That's how bad it is.
So the main disadvantage to the injectables, you're saying, is the cost.
Well, Prolia does have the risk of that osteonecrosis. That's an injectable, but
Right.
it's in a different, it's the anti-resorptive. And zoledronic acid reclassed is the little IV infusion.
Mhm.
That also is an anti-resorptive. But the three anabolic bone building drugs, Tymlos, Evenity, and Forteo, do not have this risk, but they are injectable, more expensive, building up bone.
And is insurance covering it? Most insurances are covering it or not?
Well, if you took Diane's case, with her bone density test, the doctor would have to get pre-approval to prescribe it because it's probably in a tier that is not
Yeah.
preferred by her health plan. But once the doctor submits the supporting evidence for why he or she is deciding to prescribe that, it's usually approved.
So I'm on Forteo as well, but
Yeah.
I was able to get through the manufacturer, I was able to get a coupon, and I'm paying like $4 a month.
Wow.
There you go.
That stops when you're 65, though. You may not be 65 yet.
I am.
Oh, well,
I'm over 65.
See how
Okay,
good you
well.
look? You look so good on the screen that Diane thought you were.
There you go. Thank
I
you.
ne-
Thank you,
I
Diane.
never make an assumption, but those, from what I understand, I was using that coupon. I was paying $4 a month, but that's before you go on Medicare. When you go on Medicare,
Oh,
yeah.
that's good to know.
Yeah, so I'm now paying 65 a month, which is expensive when you think about taking it for 2 years. So
Well,
anyway,
the wholesale price for Forteo can be upward of $4,400 a month.
Yeah.
So you're not paying that much, actually. Oh, I see Trina is on mute, but
I'm
she's
sorry
talking.
again. I took Forteo years ago for 2 years, and I did not go on a bisphosphonate to seal it, and I lost all weight. So if you do Forteo, you really have to go on a bisphosphonate after
Yeah.
to seal it. So
Yeah.
I have bad teeth, and I just got a new scan, and it's minus 4.5.
Oh, wow.
So I have had no fractures except for traumatic, and
You go to an endocrinologist?
I'm going to Dr. Lou at Brigham next week. Actually, I'm going to just see her by Zoom, but I'm switching endocrinologists. I've been very worried. As I said, I have bad teeth. So I've been very concerned about osteonecrosis, and I have to do something now.
Yes, well, given the low value and your concern about your teeth, one of the other newer drugs other than Forteo is a very reasonable thing that Dr. Lou might discuss with you. Like the new one, Evenity, romosozumab, is an option. And then the other one that it's similar to Forteo, but it's called Tymlos, Tymlos. That might be another one that you would, and then you would seal it, as it were. Again, when you go through it again, you can take these other drugs, even though you took the Forteo once before.
Right. Can I just say, if she were to take either one of those drugs, does she still need to take a bisphosphonate drug?
Usually, we don't combine drugs two together at the same time, but it's sequential. So what happens is you build up a lot of new bone, and then you're only supposed to take it 2 years. And if you don't do something else to, as Trina said, seal it, or to keep it, all that gain, you've gone all that trouble to gain the bone, and now you just don't want it to break down fast, which it will do if you don't seal it follow it with a bisphosphonate or with Prolia or something like that.
You know, Annie had oh no, Annie, did you finish, Annie? with your
Yes,
question?
I'm done.
And thank
My
you, Dr.
question.
Keel. We keep
Okay.
blocking you with questions, but we have them. Jane, were you next? Did we answer your question? Or how about,
Jane, you maybe you didn't take down your virtual raised hand. Sometimes you have to like
I thought it was up
remove it.
again.
Can I just ask a question about the reclassed?
Yes, Carol.
Yes, I'm going to be actually having a virtual appointment tomorrow with my endocrinologist, and I haven't taken anything, and I don't even, I just had a bone density test, so can you tell me anything about reclassed?
Yes, reclassed is when Annie was asking about injectables, it's one of the injectable in the terms of it's an intravenous. You have to hang out for 15, 20, half an hour and get this, you get an IV and they just run it in. And it works like Fosamax, but rather than taking a pill every day, you get the infusion and then you don't have to do anything for at least a year or two.
It's actually
Yeah.
really good for me because I'm really bad about taking pills sometimes, and
Yep.
and like I can have the whole pill box, the whole thing, and it's like I forget to take it. So
Right.
maybe that might be a good answer.
Yes. It's generic now, and you know, it's not that costly, and it's good for a whole year. And it's there was one of the most interesting things about that drug was that in New Zealand, one of my colleagues did a 6-year study of women that didn't even have as bad a T-score as some of you have shared with us. They were in a sort of middle range, you know, osteopenia range, as they call it. And he treated this group of women for, they followed them for 6 years, and I think they got an infusion of what you're talking about, Carol, every 18 months rather than every year, as the label prescribes. And they, even that group that weren't that severe, had an amazing reduction in fractures. So I think it's a pretty decent choice if that's the way your doctor will talk to you about that option.
Okay.
Then you
thank
have to monkey with the pills and get the refills. Oh, the mail order pharmacy. Oh, we ran out of the pills. You'll have to go to CVS and deal with all these prescription things. It gets you out of that.
Yeah,
Thanks.
it can be a nightmare, yeah.
Hey, could I ask a question? And thank you for tonight. Carol, I didn't cut you off, did I? Okay. I want to know your opinion on PPIs, protein pump inhibitors. There's been a couple of small studies. I saw a Dutch study, a couple of studies here and there, and then I think it was a Canadian gastroenterologist journal or something like that. They had a study, but then I saw that they were sponsored by some drug makers that made some of the bisphosphonates. So my gastro guy wants me to take PPI. My endocrinologist doesn't. I have a stomach ache and I'm trying to get all my calcium in. I'm so tired of dairy. It's just, I'm on this little treadmill here and I'm not taking medications. I'm exercising. I'm part of the Emerson Hospital osteoporosis exercise plan. So just your opinion on the PPIs.
Yes, for those of you who don't know what PPIs are, it's the proton pump inhibitors. Proton pumps are what put the acid into your stomach. They're inside the cells. They're like pouring acid in your stomach. And if you have acid reflux, I assume Lillian might have some indigestion after you typically, I have it, after I eat. If I don't take my medication, about a half hour after, I go, oh, there's that it's like a little, you can almost feel the
Yeah.
stuff bubbling up, and
Well, and
it
these are-
irritates you. And it's called, and the proton pump inhibitors were designed to reduce the acid and reduce the symptoms. And they became so widely used that they went generic. You can get them over the counter now and just pop them anytime you want. And there have been studies implicating proton pump inhibitors as a risk for hip fracture.
Mhm.
But then there's been other studies saying they're not.
Mhm.
So at the end of the day, there's still some degree of controversy about this.
Mhm.
But if I was you, I would try a medication that hasn't been implicated in causing fractures, but can definitely cut down the acid, like
I tried
Pepsid.
Pepsid, yeah.
Pepsid.
I didn't get any relief from Pepsid. Part of my stuff, that's good. I'm under a lot of stress, and this past year with COVID had added to that. And so I just have been, everything in here just kind of collapsed on me. And I just
Yeah.
vascular.
You still on using?
I think, I think if you're really suffering with symptoms and you have to take the so-called proton pump inhibitor, it's just one of those things, you have to balance everything. If the information's somewhat controversial about their risk, and it can provide so much good relief for your reflux, you should take it.
Yeah. Yeah.
And maybe you can also, there's non-medication ways of avoiding reflux, like don't drink coffee.
Yep. I'm into all that. Diet,
Tomatoes,
food, yep.
chocolates,
Yep.
don't mince.
Yep.
I found bananas do it to me too, so I put bananas on there. But I'm able to get by with Pepsid, so I stick with that. But if you can't and you're suffering, I would still choose to take something that will relieve your discomfort.
Okay, thank you.
Okay, well, we've been going now for an hour and 15.
I know.
And I'm going to excuse myself, I think, and try to take a little bit of a break before tomorrow, back on the Zoom.
Oh, thank you so very much.
Yes,
Number
thank you.
one, for
Thank you.
agreeing to speak to us at all. And then number two, for answering all of our questions ahead of time, which we never even expected. And then answering an hour and 15 minutes more of questions.
Well,
That's awesome. Thank you very much.
I really enjoyed talking to all of you, and I realize you all are dealing with these issues surrounding osteoporosis. And the fact that you're on tonight, osteoporosis is at the bottom of the list of most docs. They don't know what to do, and they don't even always screen for it. And you're all dealing with it. And unfortunately, we're trying to raise awareness with the National Osteoporosis Foundation is probably the leading organization for all the educational materials. They sponsor meetings, and they've just done research on how common osteoporosis is and how people are suffering with it. And it's great that you're on and caring, and you can be the ambassadors for your friends. You have to build awareness. It's not on the radar screen the way it should. And I'm a geriatrician. All my patients are older than me. That's why I went into this geriatrics thing. I always feel young no matter how old I get, because all the patients are older than me.
That's
but
awesome.
Seriously, they all, when I see how devastated it gets after a hip fracture. My mother died of a hip fracture, so it's really a personal thing for me. So I'm happy to try to help other people to deal with osteoporosis. So thanks for having me.
We're so appreciative.
Thank you, doctor.
So much.
Okay.
Thank you.
Take care. Good luck.
Bye.
Wow, that was wonderful, wasn't it?
Yeah.
Great. I'm going to pause the recording.